My name is Dr. Faisal Hassan. I come from Cleveland Clinic, Abu Dhabi, and it's indeed a pleasure to
So,
welcome.
Faisal, we're having
Hussam, I was just
technical
going to make
problem with
introductions and then we can
the
pass the
case.
mic over to you.
So we're gonna start with Francisco.
I'm sending you a CCAV document.
And I'll just introduce our
Good.
faculty over in Cleveland Clinic, Abu Dhabi. So we have Dr. Hussam Yunus, who will be moderating and also presenting a session on surgical revascularization. He comes to Cleveland Clinic, Abu Dhabi from Houston, where he had extensive training in both endovascular and open vascular surgery. We are very lucky to have him as part of our team in Cleveland Clinic, Abu Dhabi. The presentation will be made by Dr. Khwaja Yusuf Hassan, who came to us from Aga Khan University, where he completed his fellowship training and is currently a cardiologist with us. We will be joined by Dr. Andrew Rivard, who is our main go-to radiologist for cardiac and vascular radiology studies. He comes from the United States. And then finally, we have Dr. Francesco Serino, who is an eminent vascular surgeon from Italy, who has been with us since the very beginning of Cleveland Clinic Abu Dhabi and has been part of our vascular program. His expertise currently includes our vein clinic and is an expert in vein therapy as well. So with that introduction, I'll pass the mic over to you guys over in Cleveland. Hussam, do you want to introduce what we are going to do today, and then we can have the case presentation?
Good morning, everyone. This is Hussam Yunus from Abu Dhabi. Thank you very much for giving us the opportunity to present. We are excited today. We have a wonderful panel that will show us comprehensive vascular care of critical limb ischemia, including imaging, endovascular open treatments, as well as podiatry. We having a technical problem with the case, so we'll move on to the second presentation on your list. Dr. Serino is a professor of surgery here at Cleveland Clinic. He will be telling us about the role of vascular lab in the evaluation of ischemic limb.
So good morning, everyone. I'm glad to see. I just see the screen over there, but I bet you're gonna follow the presentation here. I was asked to explain what the role of vascular lab is today in the evaluation of ischemic limb. So classically, the vascular lab was oriented to sustain clinical findings with hemodynamic studies, just pressure measurement, ABI, TBI, or waveform analysis, to study the pathological anatomy with arterial ultrasound, or evaluate tissue perfusion with TCPO2 or implantable oxygen sensors nowadays, or follow results with bypass or revascularization using for vein mapping and follow-up in general. But today, the vascular lab is dedicated to something else, which is integrating clinical and diagnostic finding for a correct classification. And this is very important because classification has been the problem in the past decades for the treatment of the clinical threatening limb ischemia. And this is why, because the past classifications, which is Fontaine and Rutherford, never made a distinction with non-diabetic disease and diabetic disease, which explained the failure of past trials in basically be able to evaluate and analyze the current and tested technology using the same class of patients. In fact, with those classifications, if you were staging patient by clinical evaluation, the diabetic patient and non-diabetic patient almost had the same results, sometimes better in diabetic patients. While if you base patient that you classify by anatomy, which is the disease of the arterial tree, there's always been lower limb salvage and lower wound healing rates with diabetic patients, as you see in other territories. So clinical limb ischemia has been abolished by the Society of Vascular Surgery as a term because it does not justify the presence of diabetes enough and the impact of the three factors, which is wound, infection, and ischemia. In our territories here, and as you, I believe, in Pakistan, infection is more prevalent, way more prevalent than the other two. So we talk about today, it's chronic limb threatening ischemia because we want to include the ischemia part in a broader and more heterogeneous group of patients, where you don't have to reach the level of the threshold of the former evaluation of clinical limb ischemia, but you can treat, or you need to treat patients with a lower degree of ischemia if associated to the other two, basically the ischemia, the infection, and the gangrene evaluation. So this is what today I would like to tell. I mean, what do we need the lab for is basically achieving 3 points, which is the staging of the limb according to the Wi-Fi classification. So how threatened is the limb? And from there, always with the Doppler ultrasound and other studies, go to the severity of the anatomy tree, which is classified according to the new GLASS classification. And after the evaluation of the patient of the limb severity with Wi-Fi and the anatomy severity with GLASS, then we can plan treatment. Plan is basically it's the diagram that brings you to decide which patient to treat and when and how. This is the diagnostic flow, which is whatever the new Society of Vascular Surgery is indicating as appropriate. So you measure, you start with the pressure on ABI, and when ABI is abnormal, you go and you follow. I don't know if you see the arrow. No, it's not, but anyway, follow with toe pressures and PPI and Doppler waveform, and to be able to evaluate the limb severity. But note that even abnormal ABI, when it's 0.9 to 1.4, if you have tissue gangrene, you still proceed to measure pressure in the tibial, in the anterior, in the pedial artery. And same thing in diabetic patient, when you have ABI above 1.4, you still go and measure the toe pressure in any case. So this is basically a change from the past diagnostic pathways. The Wi-Fi, how do we go to Wi-Fi? We start always with examination. This is the most important thing. Examination, especially the wound analysis. The wound analysis in the Wi-Fi and also in the International Working Group of Diabetic Foot is based on Texas and Pettis grade classification, which goes from 0 to 3. The non-invasive studies, which are classically done with the normal pressure, the basic pressure, and the pressure index as the first line of diagnostic, can be integrated by the TP and TBI in all patients where you have also tissue loss. The use of alternative methods like PDR or transcutaneous oximetry, it is possible in absence of the first two, but it's not recommended actually. So when you grade the wounds, ischemia, and the infection, with the Wi-Fi concept, I will not go